With regards to mechanical backache, which is also non-specific backache, the source of pain may be from the spinal joints, from the discs, from the vertebrae themselves, or just from soft tissues around the region. Acute mechanical back pain is also called acute back pain, lumbago, idiopathic low back pain, lumbosacral strain or sprain. So it's important to note that many synonyms are used to describe the same condition. In terms of the physical symptoms and the clinical presentation, these clients would describe more of a muscle ache or a stabbing, shooting pain. They may have spasms, and the pain may radiate down into the buttocks and the thighs. There might be limited range of motion and flexibility, especially in the acute stages. They may not be able to stand up straight, and the pain could also be radiating from an injury elsewhere in the body. The prognosis is good for most patients who present with mechanical backache, and we hope that they would return to work sooner than individuals with neurogenic backache. Moving on to disc impairment, which is commonly seen in claims. Also, to talk about the synonyms, we might see herniated disc, a ruptured disc, a prolapsed disc, a bulging disc, and these are all terms that are used to describe the same thing. So we use disc impairment as the umbrella term, and the rest would be synonyms for the same condition. Disc impairment is where the annulus fibrosus, which is the outer portion of the disc, becomes torn and allows for the nucleus pulposus, the inner portion, to bulge out and cause damage beyond the outer rings. If you think of a sweet with a jelly-like center, it's almost like the jelly-like center pushing through the harder outer layer of the sweet. And obviously the disc, which is sitting on the outer portion, would be causing a lot of pain. It could compress on nerves, it could cause direct back pain, arm pain, leg pain, numbness, tingling, muscle weakness. And strangely enough, some people have no symptoms at all. And we obviously dealing with the individuals that have symptoms or claim to have symptoms. So the prognosis varies depending on the individual once again, and it depends on the degree of the impairment present. Moving on to osteoporosis. Osteoporosis is not commonly seen at claim stage, but it is currently a major medical problem as the aged population of the world grows. It's a skeletal disorder characterized by compromised bone mass and accompanied by deteriorating bone tissue. It's more common in women than men, and it predisposes one to fractures, and particularly spine fractures and fractures of the vertebra, like compression fractures. They could also get spinal deformities that are progressive and stenosis, and this becomes a concern with spinal surgery, and you question what the success would be if the vertebrae are not strong enough to hold the instrumentation, or depending on what surgery is performed, would the surgery be a success? The problem with this condition is that the pain worsens on standing or sitting, bending, twisting. People would have loss of height, they may get stooped postures. In terms of the prognosis of osteoporosis, having one fracture means you're more likely to have another. So the treatment focus needs to be on strengthening the bones. Doctors can prescribe medication to assist with this, and the individual can also have physical therapy, weight-bearing exercises, and a number of other exercises in order to ensure that they strengthen the bones as far as possible. With regards to laminectomies, we commonly see this procedure at claim stage. I've already explained what a laminotomy is. A laminectomy is different in that although it's a surgical operation to remove one or more of the backs of the vertebra to give access to the spinal cord, the doctor wants to obviously release the pressure on the nerve, but in terms of a laminectomy, the full lamina is removed. So this procedure is a lot more invasive, and the recovery time would also be longer. So generally, with laminectomies, 70 to 80% of patients will have significant improvement in their function and the ability to perform normal daily activities, and hopefully reduced pain. We also see that patients have lumbar fusions. Now, the lumbar fusion is where we want to join two vertebrae together to reduce the movement between them with the aim of reducing pain. The prognosis is also very variable, and it depends from one individual to the next, and we'd have to look at their comorbidities. So it's important to know what it is, but to look at each case separately. The failed back surgery syndrome is something that we see quite often, unfortunately, and it's not actually a syndrome, but it's a term used to describe the condition of patients who have had an unsuccessful result with back surgery. So they unfortunately continue to experience pain after surgery, and they sometimes notice no difference with having had the surgery. In terms of the prognosis, we'd have to look at the red and yellow flags that present. It depends once again on the client's comorbidities and the treatment regime. Do they have access to rehabilitation? But we do need to be aware that not all surgeries are successful, even though we do notice a large portion of claimants do undergo back surgery. So the important thing to get to is the functional impact of these conditions, because not every person who has these conditions would be functionally impacted to the extent that they can't work or can't perform the activities of daily living. Although it can affect this, we need to determine in which individuals this is affected and which are only wanting to portray the symptoms for gain or compensation. So we need to consider the claimant's job description. Are they in a more manual role? Are they in a supervisory or administrative role? Do they need to travel a lot? What is their work environment like? What is their mental status and their motivation? What is their return to work plan? Do they consider themselves disabled, or do they think that they're going to return to work? Do they use active coping skills or passive coping skills? And these factors are very important to consider in terms of functionality, because it's not just the condition in isolation. There's a huge psychosocial component that we need to look at, and we need to use a multidisciplinary approach in order to assess these claims to ensure we are making the correct decisions and coming to the right conclusions. So in terms of pain, the one aspect of pain that makes it very difficult to assess is that it cannot be quantified. Each individual is different, and the way one person experiences pain is very different to another. So in general, pain is defined as an unpleasant sensory or emotional experience, and it could be associated with actual or potential tissue damage. It can affect the ability, as mentioned, to perform activities of daily living, but many people can do their activities of daily living despite the pain. So in terms of assessing an individual's pain, we have some tools that can assist us in measuring pain. One is the American Medical Association guides to the evaluation of permanent impairment, although this assigns very small percentages for pain due to the subjective nature of the pain. We could also use the Oswestry Disability Index. We could get clients to fill in back pain questionnaires, and a good thing to find out is how often they're taking their pain medication. And with all these tools, we could hopefully get the most objective result in terms of pain quantification. If one is really in doubt, and depending on a number of factors, we could outsource a functional capacity evaluation, which is performed by an occupational therapist, and these individuals would determine the functional ability of the individual and give us an indication of what they can and can't do. And they are experts in this field, so if you're really not sure and you feel that you cannot come to a decision on a claim, it would be recommended that you consider this assessment. It's important to also realize, especially if you're speaking to your claimants over the phone, is that pain does not need to be totally eradicated for one to return to work. As long as it's safe and the person can manage within their levels of pain and they know how to self-manage the condition, there shouldn't be a reason for them not to return to work. And we need to try and educate them in terms of active coping skills so that they can manage in their respective work environments. So the evidence shows that being proactive rather than passive in one's approach and ensuring that one continues to perform normal daily activities is a good prognostic indicator for recovery and return to work. Work is good for one's health, and depending on the condition, we should always be encouraging that and getting